Today, one thing we're going to have a conversation about is about financing. How do we attract the kind of funding that would help us bring our doctors, our oncologists, our healthcare practitioners from those places back to Nigeria? How do we make our healthcare system one that we'll all be proud of, not just for today, but for the future, where we don't have to go spend all our money on medical tourism? And to have the conversation about healthcare financing, I'm going to invite Professor Ali Gombe. Please let's put our hands together for him. He's representing the DG NICRAT. I remember earlier, Dr. Hanatu, please come close. Oh, yeah. I remember earlier when Dr. Gafra came in and I was recognizing him, I had mentioned that I would like to have that conversation about funding with him. So, Dr. Gafra, please let's put our hands together for him. We have health insurance company representatives here with us because funding is not just about providing the finances for people, but we also need to talk about health insurance. How do we reduce the overheads for people who are receiving this treatment? Yes, we have, we're meant to have a representative from BOI and NHIA. So if you're here, could you indicate? Would like to have that conversation with you today. Okay. Okay, Professor Abidemi Omonisi, please, you're part of this panel. Thank you. Healthcare finance. Yeah. So who is moderating? Distinguished ladies and gentlemen, pardon us. We're switching things up a bit to make it more exciting for you. Yes. Thank you. Yes, if you need an extension of the conversation with the cancer survivors, we can, yeah. Yeah, sure. Oh, yeah. Okay, so I would also like to invite Dr. Motala Adoji. He's the CEO, founder, System Strategy and Policy Lab. Dr. Motala, please. Thank you. Please, let's put our hands together for him. I would like to also invite two of our cancer survivors. I'll invite two from. Yeah.
We are looking for, we want to unlock innovative funding for cancer patients. He who wears the shoes knows where it pinches. Let them speak out.
Absolutely. In fact, I think if I have my way, I'd like to invite all three because they all had unique stories. So, ma'am, please have your seat. Thank you. And I'll hand over to Dr. Gafra.
30 minutes, so we have to be very good afternoon, everyone. First and foremost, I would like to thank the organizers for putting this wonderful section together where we'll be discussing things that affect all of us. You heard me here well? All of us. So thank you very much, Anatu and team. Thank you, Nigerian Cancer Society and others organizers as well. Like I said, we'll be discussing something that affects all of us. When it comes to cancer, is it that you are affected physically, emotionally, or financially, or all the three combined? As I speak, I lost a sister to breast cancer. My brother is currently battling with prostate cancer. a member of my community is battling with cervical cancer, which we have to mobilize resources. So all of us are affected. And last Thursday, I was with Dr. Ali Gombe. Dr. Ali Gombe, is it every Thursday too? Last Thursday I was with you. And today we are discussing cancer financing as well. So when it comes to cancer financing, it's not affordable to almost all Nigerians. If you look at the five income quantiles, the poorest of the poor and others to the richest, it's almost not affordable to any income group. Because to those of us in the earth financing space, when spending exceed 10-15% of your income is catastrophic because it affects every other sources. And we are talking about, for the poorest of the poor, things that it accounts for more than 2,000% of their income. And for the richest income group, more than 100% of their income. So today, it's not about, this section is not about lamentation, but about discussion about where the resources come from to be able to address this. To kickstart the conversation, so because of time, I wouldn't have time to introduce our panelists. I think Madam has done a good job of introducing them as well. We'd like to set the stage. When we are saying we are looking for additional resources, we're looking for resources to be able to bring circle to cancer survival. And not only that, even prevention, early detection, treatment, rehabilitation, and others. Those are the things with a range of things we need resources for. I would like to go to NICRAT first, which is the government institution saddled with responsibility of treatment and other programmatic areas are needed to bring circle to cancer patients. So Dr. Ali Gombe, like I said, I was with you last Thursday, I'm with you this Thursday, maybe next Thursday we are going to have another engagement. I want you to quickly give us an overview. What is the funding gap for cancer care financing in Nigeria? Over to you, Professor Ali Gombe.
All right, thank you very much. Cancer, like any other disease, the burden, it's very high, and also the costs of both preventing and treating cancer in Nigeria. If you were at the Peking launch, for instance, the cost of eliminating cervical cancer alone that was put by the committee that estimated cervical cancer elimination costs in Nigeria, it was put only around 2.2 trillion naira for cervical cancer alone. Talk less of if you combine other cancers. And cervical cancer is not the most common cancer, and also there are other more prevalent cancers. So if you compare that with what we have in the budget for cancer control, both at NICRAT and also in other agencies, you realize that a cervical cancer alone is not, the amount is not sufficient to control cervical cancer alone, talk less of other cancers. And the other also factor is that what was mentioned earlier, most of our patients pay out of pocket. So in terms of treatment, less than 10% of Nigerians are insured. And also, even those that are insured, the insurance does not cover all the cancer treatment aspects, as well as of even prevention and other screening, for cancers. So, and also, if you look at the budgets, for instance, even though government, in the first place, we don't have a budget for cancer. In 2024, we had a budget, and then in 2025, we now had a budget that is 5 times the 2024 budget. That is an increment, but there is a very wide gap between what we need and what we have. Thank you.
Okay, thank you very much, Professor Ali Gombe. That's summarizes it at a helicopter view in terms of looking at the huge burden for each of the cancers prioritized by NICRAT. The resources actually, to start with, we have to thank the government of Nigeria for even coming up with the cancer care fund, CH fund. And whenever I listen to the story of the survivors, it's actually very, very encouraging. But the story is that there's still huge gap in terms of finance. Before I come to the National Cancer Society that is putting in place a very, very robust arrangement for mobilizing resources, it's always, they say, he that wear the shoes know where it pinches, right? I would like to go to one of our survivors to give us a human angle perspective, a legal-based policy angle perspective. So, how does having to pay out of pocket affect us holistically, affect our family life? And how does government come in to intervene, bring a support to us? I want to hear from you in terms of, I was diagnosed with this. They told me it's going to cost this, and when I compare it to my income, some people say I almost fainted and all those stuff. So I don't know, let's be democratic. Do you want to choose who speaks? Madam, your discretion. Okay, just tell us in any plain language how the issue of funding and how happy you felt when the CHF came to your rescue.
Okay, like I said earlier, my name is Linda Budu. The finances, you won't even know where to start. For me, I am self-employed. I do business, but everybody knows here business has been down. When it comes in the finance, of course, my family were there, but I didn't see them. I thought I had family. I thought I had friends. But when I needed them, nobody was there. I had to sell, virtually I sold everything that I have. And I'm still selling to treat myself. It is not easy. Like I said earlier, I said it, when I talk about it, at times I get emotional, but it's not easy. You know? Like I said earlier, I said I took, 4 physical. When you do the calculation, do the math. When I was doing my chemo, virtually I was spending 2 million. Where is the money coming from? I sold my gold. I sold my car. Everything. So it's not easy. Anyway, this is it.
Okay, thank you very much, Madam. Do you have any of colleagues that want to add to that? That is touching enough. But is there anybody that wants to quickly add to that? We'll come back to the audience, please, so that we structure this. It's okay. That's fine. I think you can have a glimpse of what it takes, the financial cost. Absolutely. So I think we can have a glimpse of what it costs. Madam, you are even lucky that you have a gold to sell. Many Nigerians are not in that actually category. And Madam said something earlier which is very, very important, that probably family members were nowhere to be found. It's not because they are wicked. Excuse me, one house. It's not because they are wicked, but when you hear the amount of money needed, you ask yourself, where do I start from? So also the family member will ask themselves, where do I start? So it might look as if they don't care and all those stuff. It's because the resources wasn't just there for them. Because Africans are very, very caring. In fact, if there's anything that separates us from the other parts of the world, is the family cohesion and all those stuff. When the money is not there, it's not just there. That is the issue. But the good thing is that, like we said, Cancer Health Fund. But when I listen to my friend, the prof, and the president of Nigerian Cancer Society, they have a very, very interesting arrangement in terms of how to mobilize resources. So on this note, I'll hand over to Professor Monisin to tell us what is Nigerian Cancer Society doing to actually mobilize more funds to alleviate the suffering of the cancer patient. Over to you, Prof.
Thank you so much, sir, for that. Well, let me say that Nigerian Cancer Society, as a president, every day I receive call, from survivor. I'm happy they are here and they have said their story. In fact, as we speak now, many of our survivors are not on medications. They cannot afford it. Because all family support, people are already fatigued. Many of them sold their vehicles, sold their houses, their resources to start the treatment. They've been on for some time. Brother contributed, community contributed. Everybody is even tired of contributing. And majority said they've resigned to faith. That is their word. Prayer and faith. They are up there because they cannot afford it. Of course, the fluctuation in dollar also make things worse. I mentioned earlier before, breast cancer survivor will need average of 22 million, as extra hospital admission and other costs. How many individuals can afford that? Just one of us, a medical doctor, has done cancer, and their mobilization of resources, they said they need almost 18 million, and they put on a platform and we start contributing money. That's a medical doctor, because he can also afford because of treatment. So if a doctor, a consultant, cannot afford because of treatment, what happened to the woman selling pepper or rice, etc.? So it's a major issue that we need to confront. Cancer, funding of cancer treatment is a major issue in the country. We must appreciate the federal government for doing something, but what they are doing is grossly inadequate. Must still accept the truth. Grossly inadequate, because it's only covering for 4 cancers. I know for 4 cancer, Amapi, Professor Ali Gombe have mentioned, is not widely funded. Childhood cancer, 50 million budgeted for the entire country this year. What would that treat? 50 million. For other cancer, prostate, cervical breast, and almost 300 million. What would that treat? In the entire country, I'm not saying FCT, entire country. Sometimes it's under pressure. People call them, disburse money. What? 300 million for 4 cancer for the entire country. It doesn't sleep. He had headache. How do we go about doing this? Because it's not funded. So what we have decided to do as the Nigerian society, we have taken our destiny in our hand. Because all cancer survivors, they are members of our society. As I've said, we are under pressure to do something about it. What we are doing is to we set up a governing board, council that we call NCS, Cancer, National Intervention Fund. And we are raising 100 billion to support cancer survivors in their treatment. And they will cut across all cancer, whether it's prostate, it's breast, hematological, lungs, And we have carefully looked at people that can make this happen across the country. People in the health system, not only, cancer survivors are also there. Because that's one mistake we have done in the past. We make policy for cancer survivors. They are not there on the table to come and contribute their quota. It's people that have no cancer that will now be telling this what we should do. Can you hear their beautiful story this morning? Can you hear their story? So people that have cancer are not even there. Doctors and healthcare policy now deciding their fate. They've gone through the treatment, they have the story to tell. So the Cancer Intervention Fund we are setting up, they're also there. Matter of fact, the former First Lady, those states, Dr. Betty Akedo, she's the top, number 1 cancer survivor in this country, almost 30 years now. She's still counting. She's there. The chair of Lagos is the cancer survivor. She's also there. So they are there to ensure that that money is properly, administered. We have lawyers, we have community people there. Emir in Yobe is also there. I'm not there as the president, unfortunately, and I decided not to be there because I'm an independent fund. And luckily for us, he accepted to chair the governing council. People that know Dr. Gafai, when it comes to health system financing in this country, after Professor Ali Pate is number 2. And 2 of them, they work together anyway. They work together. When it comes about, he has contributed a lot. People don't know, he's a giant, but doesn't make noise. But he has contributed a lot at the background, driving international funding to this country. He worked very closely with the minister. So we selectively approach him. We know he's a very busy person, but I have to reach out to him because we are classmates anyway. So he can't say no to me. I told him, if I fail as NCS president, you have also failed. So he accepted to share that governing board. We have people from the banking industry, all background. And we presented that proposal to the Minister of State for Health, in charge of cancer, and he has accepted that, and the country has adopted that for the country. And we'll be launching that governing board next week, Friday, Prime Minister of Health. In fact, the Honorable Minister of State for Health personally will be there to inaugurate that funding. So that will complement what NICRAT is doing, work together, but we need to pull out that muscle. Let this private individual, Nigerian Governance Forum are keen to it. Private sector alliance are keen to it. They will drive funds. They know how to bring those funds. And once, they coordinate it in a very transparent manner, to work. Look at to round up, look at NNPC. NNPC every year they budget billions of US dollars for routine maintenance. Just a few days ago, we are told that it's unlikely that any oil will come from that NNPC. Can you imagine that after funding to tell you that we must key into public-private partnership. Anything solely owned by government or run by government, it's unlikely to succeed. That's the truth. There are a lot of issues there. So that's why we have set up this as independent fund where we mobilize principally from the private sector. To help us drive the floater will be the one managing another profile in the car wares. They will be the one managing and disbursing the fund. It's not NCS. So it's a very open system. And also bringing in some youth advocates to be there, so that if something is happening there, they can shout. This is what they are doing. So with that, our concern is to help the cancer survivor. We have no motive to help them, because that funding gap is obvious to us.
Okay, can we appreciate Professor Morrison for that wonderful thought, wonderful idea, and the thought around how to be innovative about mobilizing our resources, because like he said, our government alone cannot do it. Even government can be committed. Professor Aligombe is a witness. Money could be allocated but not released, and part of the problem is that is why we have to think outside the box. And thank you very much for thinking outside the box. And thanks for the compliments anyway. So like he said, private sector is going to be very central to the innovative approach towards mobilizing additional fund. Private sector is a bit different from public sector. They have their motivation. You have to understand the political economy and everything. I would like to ask Dr. Murtala, what does success look like? How do we ensure that we are effective in mobilizing private sector participation when it comes to mobilizing resources? Dr. Murtala.
Thank you so much, the moderator, for giving me the opportunity to share my own view here. I think two things are very important here. One, to look at the need. One is what does success mean? Success means increasing the Nigerian GDP spending and the health sector generally. At the moment, Nigeria is spending less than 1% of the GDP in the entire health sector. The WHO and the World Bank recommendation is that Nigeria needs to spend 4% of the GDP in the health sector. So success means having an increase in our spending from 1% of the GDP to 3 to 4% of the GDP. That is number one. Number two, success also means every state governor being able to capture cancer-related issues in the state annual budget every year. And significant percent of the money, about 70%, being released to the state's Ministry of Health. Success means at the federal level, we have an increase in the budgetary allocation, and the funding is being released, and a significant percent of the cancer patients have been treated or have been taking proper care of in Nigeria. This is what success means. Success means there's a limit to how we can rely on private sector. There's a limit to how we can rely on donor partners. Because with the Trump disruption of the funding from USAID and other international space, no matter how we launch the funding, no matter how we try to bring the Bill Gates and others to come and support us, how far have we gone in our own as a country? Mr. President has removed subsidy. Over billions of nairas have been generating from that subsidized money. Where is the money going? That is where the health sector financing need to critically look at and say how much are we being allocated to the health sector with specific capture in the budget. I think one advocacy issue that we need to push at higher level and also at state level is that we need a separate budget line for cancer. In the budget, a separate budget line for cancer. The health sector budget should be there. But hiding cancer in a lump sum or other health issue might not help. Let's have a separate budget line to know how much every state is budgeting. That would be a success to us. Thank you.
Okay. Thank you very So thank you very much. That was very succinct and very, very clear in terms of how even prioritizing the public spending. I totally agree with you. Probably in addition to what you say, what you have to look at, you have to ring-fence money. There are discretionary allocation and there are ring-fence sources, which probably later on when we are talking to our lawmakers, probably we need legal framework to help us ring-fence certain amount of money so that it becomes statutory in terms of allocation, not only at the national level, including subnational level as well. And now we are going to get local government autonomy. We have to talk to our local government chairs as well, because these things actually affect everyone. Thank you very much. So let's look at the health insurance space. So a couple of years ago, I had a prostate cancer patient, and it's a civil servant. And I asked him, for crying out loud, you have health insurance. He said, oh, my health insurance does not even take care of a common fasting blood sugar. Why will you take care of I said, really? And we started exploring. And at the national level, we talked to them at the National Health Insurance Authority, and we discovered that, you know, actually the benefits package actually covers it. At the end of the day, from the National Health Insurance Authority, my patient was able to get radiotherapy and chemotherapy. But the question is that, is it every Nigerian that has the luxury of talking to somebody at NHIA? So now let me talk to the expert in the field. How do we ensure that cancer patients, if they are lucky to be enrolled in any of health insurance scheme, are able to get the benefit of cancer care? Over to you, madam.
Thank you so much, organizers. Thank you, sir, for this opportunity. My name is Tina Onofiage. I work for Life Action Plus HMO, Health Insurance Industry, with the zonal manager in Abuja. Okay, how will this issue be resolved? Just what's the question you are asking? How can we step into this? How can these cancer patients in their remote areas, in their various homes, and or probably in their parastatals, who does not have the idea of what their cover is, how can we reach them? The answer is sensitization. Sensitization, and that is what NHIA advocates that HMO should do. And this we do every three months. And going back to how can insurance, what role will insurance play in ensuring that cancer care is taken, is innovative also? What can health insurance do? One of the things health insurance can do to totally or to reduce to the barest minimum the burden of financing cancer care from the participant or from the patient is that they can customize products that can take care of cancer. You see, in the products or the product line or the health plans that are being sold by most of us, the health insurance companies, cancer is one of the exclusions that we have. Is an exclusion. Like in my HMO, cancer is a limited services. Limited in the sense that you are only covered for consultation and probably the diagnosis. Then the treatment is an exclusion. So the health insurance can now come in this manner. Let's customize a product, this cancer product. We will say, okay, this product is cancer care. Then we'll give it a premium. We'll give it a premium that will be given out to the various organizations and people who want to buy it. Okay? So once we give this out to them as a product, we know that the financial burden will be borne by the HMOs or the health insurance. So this alone can give the patient a rest of mind of thinking, who is going to pay? Who will pay? Who will pay for me? So if we have such products, which we are also looking at, thinking about, will reduce the burden, the emotional burden. Well, of course, we know that cancer is not just a medical crisis, financial crisis and emotional crisis. So if you are able to remove the emotional crisis, and reduce the financial crisis to a bare minimum, I think we can have a good landing. We can have a good landing on this issue. So I want to beg all the health insurance can't do it alone. In 2022, NHIA came up with cancer, mandated cancer, make my cancer mandatory for all the public sector. So bringing it that the enrollee can pay 20%, why the government of 80%, just like what you said. Okay, so some of these enrollees are not aware. Okay, so this 80% is not just being borne by NHIA only. We are collaborating also with some pharmaceutical companies like Roche, like Pfizer, to ensure that these things are achievable. So this move we started in 2022, I'm sure if we give it more push, if we give it more attention, if we ensure the policy is working, this problem, give it a time, like in 5 years, cancer issue will become a breakthrough. And many people will not be suffering from cancer and nobody attending to it. Thank you.
Okay, thank you very much, madam. There are a lot of important points that stood out from your message. One, even when cancer services are incorporated to the benefit package health insurance, what is the level of awareness, increasing the awareness? Where it is not part of the benefit package, how do we include it? But there's a nexus between what NCS is doing and what we are talking about. Health insurance firm will not include services that can crumble their system there, but if there is a special intervention fund where they can rely on, I think that will be very, very helpful. So let me quickly go to Professor Aligombe. Professor Aligombe, you listen to Professor Monisin nicely describe their intervention that they are trying to build. From somebody that operates cancer care management program, what advice do you have in terms of, as we mobilize this fund, what should we do differently so that we are able to mobilize fund fit for purpose, it generate a lot of money, but at the same time ensuring that the money is available to do what is necessary? What advice do you have for Nigerian Cancer Society?
Thank you very much. First and foremost is what they have started doing, that is stakeholder collaboration. That is key to, you need to have stakeholder buy-in, because this funding will not come if people do not believe in what you are going to do. That's the first thing. The next is also transparency. You need to be transparent in all the processes and make sure that you give audit reports of how the fund is spent at intervals. That will encourage the donors that have given the fund to continue to give, and then new people to also come into the funding. The other aspect is selection criteria for the indigent cancer patients. You also need to have a very good care criteria for select who benefits from that fund. That has to be well captured. And also the process of application and selection should be very simple, even though it should entail the good process of capturing and also assessing the patient, but it should be very easy for the patient to access. If there are multiple steps, if there are complex approvals processes and a lot of bureaucracies, it makes the whole process to be delayed, and thereby making a disbursement of the funds, even if available at the end of the day, long time. But cancer does not wait. Maybe patients apply and then they stay for 3 months, 5 months without the fund. Some of them will have died by then without accessing the fund, and then when the money is coming, they are gone. The also other aspect is, which is very important, is community engagement. You have to engage. People. You may be doing something very fantastic, but people are not aware of what you are doing. So you have to engage the hospital community. Start from there. Explain to them what you want to do. Get their buy-in, and also move into the community. Religious and traditional leaders should also, so that they will guide people accordingly. Thank you.
Okay. Let's appreciate our Professor Ali Gombe for that as well. That is very clear. And I'm very sure there's going to be a handshake between Nigerian Cancer Society and ECHAlliance so that we don't duplicate effort. Things are actually as seamless as possible. Maybe one other important point to add to this very important thing that you said is how do we change the narrative when it comes to advocating for funding for cancer care? Are we just talking from the point of view of, oh, we have cancer patient that needs money? But are we articulating an economic case as well? Because there are a lot of, there is economic burden of cancer. There is a productivity loss as a result of cancer, which is an economic issue. So because we have to be very careful when we are talking to the Minister of Finance and all those stuff, there's a language that they understand. Unfortunately, they don't understand much about language of disease burden. But they understand the language of if I'm able to take care of a vast productivity loss, it's going to contribute so percentage to the GDP and economy of Nigeria. I think we have to do something differently. I made a presentation of that last week as part of what we need to do. So in the interest of time, we'd like to take a contribution from the audience, maybe a couple of contribution before. Okay, sir, I can see only from this side, right? Okay, and let's banda the. Okay, so we have our elders in the room. Let's take care of them first, and there's a young lady at the back and others. Over to you, sir.
Thank you very much. Well, I want to thank the members of this panelist for this initiative. I only hope and pray that all these things they are talking about comes into fruition. You see, when the initial catastrophic fund that metamorphosed into cancer aid fund was envisaged, we envisaged that along the line, individuals, charitable individuals will come in and contribute, because we know government alone cannot do it. Government, even if it is 4% that they contribute, it will still not be enough. As I'm talking to you, Abuja Center alone for this cancer aid fund, we have accumulated more than 500 patients. Even if NICRAD gives us all the 300 million that they are talking about, we will exhaust it in 2 months. 3-4 meetings, we will exhaust it by allocation of funds. So they will always be under pressure, because we are always under pressure. We don't see men here. I don't know why Dr. Atuji bring men here, because men also cry. Men also cry. We were talking about men are not strong as you think, because prostate cancer alone, the cost of Zytiga for 1 month, which they take for 1 Zytiga, is now 1,090,000. 1,090,000, and it's also less Zytiga for most of them come in metastatic disease. And when it's metastatic, they need Zytiga and some other thing. So they need about 1.5 million every month. So if these funds was available, but the drugs are not available again, because, for example, National Hospital CHF, we have not paid for the services we rendered last year, which we have 160 million in our account at TSA, but it cannot pay all the money that we owe for last year. This year is already more than halfway through. We are owing about 200 million. So even if NACRAT give us all the 300, and they cannot give us all the 300 million, because we are not the only center. There are 6 centers across the country. Even if they give us all the 300 million, it will not be enough. We will exhaust it in 2 months. Then, because we cannot stop, nobody is telling us now that we should stop accruing patient. We kept on accruing patient, accruing debts. In fact, I was discussing with the director of clinical service. I said, the way we are going, are we not going to run down the national hospital the way we are going, because the patients are accessing services upfront. So we don't know when the fund will come in. We don't know when we'll get the fund. So government cannot do it. That's what I'm saying. Because what goes around also comes around. Nobody knows who is going to be affected in future. So all these efforts, if they materialize, you don't know who is going to benefit. I might be. Anybody can be the beneficiary. Absolutely. So it's important we drive this thing further, because government alone cannot do it. That's what I'm saying. NICRAD will not give us all their funds. There are 6 centers they are supposed to take care of, but they cannot take care of our own needs alone. We alone at National Hospital, alone, the Cancer Fund National Hospital, we exhaust all their money. So I pray and hope that all these initiatives come into fruition.
Thank you very much. Thank you very much. That's for them. Lay credence for the need for us to mobilize additional resources. Let's take care of. Let's him ask his question.
Thank you. Mine is
Okay.
question and comment. The National Health Insurance Authority. It's been on ground for more than 20, 30 years. We should be moving and not crawling. From, I'm hearing 5%, 10%. What happens to the others? The issue now is, and when you said it's limited to only initially 4 cancers, though somebody came last year and said, oh, they've increased it to 10. Everybody has his or her own human right. The fact that somebody has breast and somebody else has lymphoma, they should have the same access. Even we're talking of children's pediatric cases here, since we started this morning. Who is talking about them? Are they not human beings? Is it because they cannot talk? Or they cannot express themselves? And my friend, Ali Gumbi, I'm happy you are here. In fact, if you have disappeared, I would have been mad at you. Because these are the people that should take home what we are discussing here. That bureaucracy, please reduce it to the PRS minimum. I've keyed a patient for the fund, and 4 months on, no access. Look, these patients, what they are going through, you've had it since morning. And the question now is, who will regulate these our pharma companies? No trials are being carried out here. People just import drugs, and even to the CHF, they get access into that place. And I'm saying this with what I know. Look, a drug like Zytiga, which he mentioned, I just received a call here of a patient who told me, sir, I cannot continue, just after 1 month. I said, you have to. Because to even buy the generic is costing about 1 million. So those people bringing the generics from India, from anywhere, they shouldn't just bring in their drugs. Clinical trials must be carried out in Nigeria, and they should pay for it.
Absolutely.
In countries like Egypt, South Africa, Morocco, you cannot just bring any drug and say you are introducing.
We totally agree with you that the point well noted. Thank you very much for that very important point. Let's appreciate for that. Quick one, Dr. Anatu, to take 2 more from the bar.
Good afternoon once again. Mine is to the insurance company, because we've been talking government. Government cannot do it all. The joke that comes to my mind, and I say insurance company, I think if we look at all of us here, virtually average, we say we all have 1 vehicle, and we pay what this VIO who call insurance, that you don't even know what
the third-party insurance.
Thank you, yeah. I think can something like that to be introduced by this insurance, that there will be a policy? Because my question is, this policy and then implementing. Third-party insurance is, I would say, is a policy, but who is implementing it? Who is enforcing it? The money is inside somewhere, enriching the pockets of who? Can't we have something like that for health? But this one now, very strict, that this insurance company, when you have to assess it, you are able to assess it. I think people will even subscribe to it and park my car at home and walk, rather than pay that money to the third party, or what they call it. So, to Madam.
Okay, thank you very much. We'll come back. Dr. Anatu, quickly.
passionate plea. We Nigerians, we are our brothers' keepers. We are looking for innovative ways of funding cancer, and we know that Cancer Health Fund has tried, but the truth is we need other forms of sources. So we are seeking out, pleading that philanthropists and even the private sector, that was why we invited banks, insurance companies. We want them to see the human face of cancer so that all those percentages, the risk percentages they put in for business and for funding programs, they will have to look into that. And there are other mechanisms too of funding the health sector, which I know Dr. Gafar will talk about. The philanthropists, we have Nigerians that have resources, and this can be channeled towards supporting our cancer survivors. They are parents, they are daughters, they are wives, they are neighbors. They are not just a statistic. They are human beings. They are our neighbors, they are our friends. And if there is how they can get support, we are pleading to philanthropic organizations. We know that generally there's a funding issue globally, but there are private sector investors, there are people that can support. So we are pleading that please they should come to the aid of our cancer survivors and patients. Thank you.
Okay, thank you, Dr. Anatu. We are going to address that in a short while.
Yeah, thank you. My name is Folosho Adenero. Let me stand on the existing protocol. Like my colleague rightly said, we are looking for the innovative and which is presently on board what we have been working on to make sure that the cancer patients are covered under our HMOs. And sincerely speaking, I think it's a very good opportunity that we have been invited to be here this morning. I think I will be discussing personally with the Commissioner of Insurance. He's my former boss and is my father. So I'll be discussing with him. So we need collaboration between us, the regulatory body of insurance, the NHS, which we're going to discuss extensively on needs, on what we need to do. But before then, before even getting to the cancer stage, we as an insurance practitioners will develop a product which many Nigerians are not keen to it. And the product, we call it critical illness. And that critical illness covers cancer, kidney failures, lungs problems, etc. But majority Nigerians does not keen to it. So what we're trying to say is that if this product was keen to before detecting the cancer, there is a fund that will be available to the tune of probably almost 10 million that they can make use of their treatments as gone. But the problem we have in Nigeria, awareness. When you go out there to create the awareness, majority people, the way they see us is insurance. Don't mind them. They are 419. But I must tell you, I have a patient that before he had a kidney failure was keen to the critical illness, and presently now it is the money that he's using to treat himself. So don't see us as 419. I'm telling you, we are there to provide solution because we understand financing cancer patients is demanding.
Absolutely, absolutely.
It's demanding.
So thank you very much. I think that point is well noted. We will not see you as 419. Probably if you remove the mask, you'll be able to see the identity. And thank you very much. That's a very important point. Over there. Okay, great. Yeah.
Good afternoon, everyone. My name is Hajara Osman Mohammed. Permit me to call Mr. Sani, my brother. Stand up. Sir, you mentioned that nobody spoke about pediatric issue on cancer. We currently have a daughter that is 4 years old, hospitalized at National Hospital. She has undergone 2 sets of chemo and it has failed. The parents are looking out for support. So this call or plead is going to the convener, Dr. Hannatu, the NCS president, and the professor. Please, sir, we would want to know how to apply for the support for the child. She's just 4 years old, so that by next year, we will be able to count her among the survivors. Thank you very
Absolutely.
much.
That's well noted. I'm sure they will respond to that. Last from. Okay, yeah.
Hello, good morning. Thank you, distinguished speakers. I really learned a lot from today's section. So I just wanted to bring up a concern. Thank God we have a representative from one of the HMOs. There's a problem that is often overlooked in the healthcare system, and that's, getting into NHIE is a different ballgame. For some people, it's very, very hard to enroll them. Now, for those already on NHIE, when they come for emergency issues or when they are sick or when they come for follow-up. And we know that follow-up routine screening is very, very important for preventing cancer in patients. So there is an obstacle that they normally get to that limits them from coming to the hospital. And that is that gap between the HMO and NHIA. So you have a lot of time, a patient comes in and wants to get their, I think they call it code or something, right? And you see them standing on the line for 1 hour, 2 hours, 3 hours. They are delayed unnecessarily. And when you go there and, oh, my patient has been waiting, they say, oh, the HMO has not gotten back to us. I just want to understand, what is the NHIA doing to prevent HMOs from frustrating patients based on that long wait time? And sometimes when you make your diagnosis, they send it back to the patient and they're like, oh, that we can't cover for this. And then you can imagine a patient that has been contributing monthly to an insurance scheme and is told that this, based on this diagnosis, that his HMO doesn't cover. So all these irregularities, in the end, you have patients that just decide to not even use their insurance. They pay out of pocket and just abandon the insurance. So that statement he made about saying HMOs are scam, insurance are scam, it comes from, there is a history that brought about that kind of statement. So what is NHIA doing to ensure that HMOs don't intentionally or by mistake frustrate patients from receiving their services? Thank you.
Okay, thank you very much. On apologies, we have to move on. On that note, we have a representative of NHI in the room. It will speak to some of those observations. But at the same time, there are packages from the NHI. Vulnerable Group Fund is there, the which the DG is actually pursuing actively. So on this note, let me quickly invite Dr. Bashir to quickly give us what is NHI doing to support expansion of cancer care in Nigeria.
Thank you very much, Dr. Gafar. Good afternoon, ladies and gentlemen. Part of the project or program NHI has embarked on to expand care to health insurance, especially as it relates to cancer care, is what we call the Cancer Cost Sharing Initiative, which we are going into collaboration with our pharmaceutical companies. I saw Roche somewhere here. Roche is part of the pharma companies that are engaged in the cost sharing initiative for some of their molecules. We also have the Johnson & Johnson. Then there's another pharmaceutical company where 50% of the cost of the molecules are taken care by the pharmaceutical companies. NHIA funds 30% while the patient is allowed to foot the bill for the 20% of the cost of care. Even though it's not practiced across the nation, we have some centers of excellence, about 7 of them, in Kano, in Zaria, in Abuja here, Benin, Ibadan, and I think University of Nigeria in Suka. Then we have also Federal Teaching Hospital in Gombe. Of recent, we've signed a memorandum of understanding. We also want to expand it to that and other centers of excellence for cancer care. In addition to that, NHI also cover for cancer screening, as well as preventive strategies, as well as some investigations, and even some management, including including radiotherapy, but that comes under what we call partial coverage. My brother here talked about issues around catastrophic funding. Cancer is one of them. If we allow everything to be paid for, if you know, health insurance is a business of number with cross-subsidization. There are some disease conditions, chronic non-communicable diseases, that if we bring them completely, they are going to wipe the funding. So that is why some are under partial exclusion, while others are under full coverage, like the investigation, screening, and what have you. In addition to that, there is the Vulnerable Group Fund. Dr. Gafar has alluded to that, which is a fund that is meant to take care of the vulnerable segment of the population. Following the signing of the Act in 2022, the President alluded to that, and we have started receiving funding as budget stream to that effect, even though it's nothing to write home about. I think this year is just 5 billion, which cannot even cover overhead cost, but we are working towards it to see how we can expand the funding. We had some projections. We need about 1.3 trillion to cover for the 83 million vulnerables that we alluded to in the Nigerian Lancet Commission that are classified under the vulnerable segment of the population. So if you can imagine what we need, 1.3 trillion, we are getting just 5 billion. I think it's far away from the cry. But we are not relenting, we are still struggling. We can also expand to cover the cancer patients. Some times back, we went into collaboration with NICRAT. I was part of the National Technical Working Group to see how we can look at our experience in strategic purchasing, part of the catastrophic funding and the cancer fund, how we can also use part of it to pay for the cancer patients. But I think it's still work in progress. So these are some of the initiatives that we are employing with regards to cancer care. In addition to that, I will quickly respond to one of the questions that was asked with regards to code and what have you. NHIA has increased its fee for both fee for service and capitation. And because of that, we have also strengthened our enforcement visits and activities. And now we've even introduced a 1-hour policy for courts. The moment you apply for court, an hour later, if you cannot get it, you can call our call center and report, and NHI can even override the role of the HMO and provide the code, and care can be accessed. The problem is awareness, and my brother here mentioned it. A lot of people enroll into NHIA, they don't even know what they are entitled to. And every rational thinking health economist want to maximize profits. If you don't know what you are entitled to, you can be swindled. You say, I have this, they say it's not covered. I have this, it's not covered. And you don't take any effort to find out whether it is covered or not. So please, information are flying all over the place, but I think we need to do much. At individual level, we should also try to find out what are we entitled to, what are those services or programs that are covered. Thank you very much.
Thank you very much, Dr. Bashir. That's highly appreciated. So before we continue, please, I want to appeal to our people at the entrance. Please, can you lower the volume so that I will be able to have a meaningful conversation here. So thanks for those wonderful questions and contributions from the audience. What we are going to do now, I'm going to go to the panelists. They are going to give us their last thought and try to respond to some of these questions raised by the audience. So, so there's a question around, okay, some of the questions are directed to the NCNC. There's a question around how do we ensure this, what we are designing is not going to be another talk, the NCNC will answer that. But do you want to answer some questions around commodities and everything, regulating it and all those, so why you give us your last thought?
Okay, I want to start with the child fund that they talked about. As we speak now, the National Cancer Health Fund does not cover for pediatric funding. But what is NICRAT doing with respect to that? NICRAT, engaged in collaboration with Roche and some other partners, engaged the National Assembly members in October 2023, and then we now push for a childhood cancer fund, which is a separate line from that of the National Cancer Fund. It was appropriated in 2024, but when the budget came out, the money was not to write home about. Actually, it was placed with other things, about 5 million naira or so. So it was not utilized. However, this year we have made another progress, and the progress is that by this year we have now a standalone budget line, which is the Childhood Cancer Fund, with about 50 million naira inside. I know people have been complaining that we have only 50 million naira, but we need to understand that we are coming from nothing to something. So now what we need is to improve on what we have. And last week, based on the program that Dr. Kafar was saying, we still engage the National Assembly on the legislative network on cancer, whereby one of the purpose of this engagement of National Assembly in that meeting is to bring to the attention some of these things that we're discussing here, so that we'll be able to upscale. So we don't have to wait for next year. There is supplementary budget, even next year's budget. These are things that, since it has come out now as something that is a budget line in NICRAC, we'll be able to make sure that it will find a way of increasing the amount to a significant number. But like we said, we need to continue to talk and convince everybody, especially the stockholders. Okay, we are going to launch the Childhood Cancer Fund based on the amount that we have. Maybe in the next 1 or 2 months, we're engaging stakeholders. We want to visit some centers so that when we start, at least we will not have, based on the experience that we had in the NCHF, so that those problems will not be there. Okay? But what I will advise now is that there are 2 or 3 ways you can maybe sort this one out. There are a lot of organizations, even in Abuja, NGOs that we have been working for that are supporting the childhood cancers. There are some that are basically only for childhood, while some are working for others. They have been supporting a lot of the patients. So I think you can, use some of them that you have, so that you can utilize that fund. And the other aspect is also, utilize philanthropic individuals, can also be utilized. And then, when this Childhood Cancer Fund comes to life in the next 2 months or so, we will now be able to consider your patient, but you have to do something between now and then, okay, by God's grace. So I'll just maybe collect one of the contact from one of you so that I can follow up when the Childhood Cancer Fund comes to life.
So any final reflection for this conversation?
Okay. All right. The cost of cancer care is enormous. Sometimes, even if government is doing something, that may not be enough, because if you gather the cost of the total budget of Nigeria, not only healthcare and the health, is not up to what we need to finance cancer care in this country. It is 52 or 54 million trillion. I mean, it will not finance the cancer care burden that we have in this country. So everybody has a part to play in the cancer control. Thank you.
Thank you very much. Everybody has a part to play. Thank you very much for that final thought. Let's appreciate him. So, Madam, any thoughts around the health insurance ecosystem? What can we do differently?
Okay, thank you once again. What I wanted to just add up is that from all the discussions, we've not looked at the early detection stage. If we want to control costs and we want to ensure that the funds we have is adequate, we should detect it earlier. If we take an advocacy for this now to this, I'm talking to Madam Anatu on this. Let's look at advocacy for early detection, because the cost for that is not as high as when it has overblown. So let's take an advocacy for that. Let it be part of one of the things that we want to embark on this voyage that we have started. Let's take an advocacy for early detection of cancer. With that, the fund for it won't be enormous and it won't be burdensome. So if we can start with that on this, I'm sure we'll make something good out of it, ma. So then for NHI or for HMO, which I stand for, I will also say that we will take this home and see if we could customize a package, just like what she was saying for the insurance, of where all Nigerians will contribute, and from the contribution, from the funds that we have contributed, we will be able to help or take care of 1 or 2 people who is down with it. So please, let's take note of this. Then Lastly, is that it is not a one-man show. I'm sure that is why the organizer of Connecting the Dot Innovation and Cancer Care has put this together. Please, let us all put hands together. It is not a one-man show, and the money or the funds here is not small. So it cannot be borne by just one aspect of the society. Let all of us put hands together. And since this is also being just like she was advocating for philanthropies, everyone who have humanitarian heart to be part of this, let's not hesitate to join. Thank you.
Okay, thank you very much, Madam. Professor Monisi, you have this very, very ambitious thought about putting huge resources together from public, private, philanthropists and everything. What's going to be different this time around to ensure that this is not just going to be on paper? How do we translate it to action and reaching the life of a cancer patient?
Thank you, sir. I'll just give a very short story. When I'll be inaugurated as the president of the Nigerian Cancer Society on Friday, 1st of November, 2024, some survivor approached me, after the election that I emerged. If one of them came all the way from UK, and they met with me, and then they pleaded with me that over the years, cancer survivors have been neglected in this country. And they approached me and pleaded that if there's one difference I will make in my administration, I should take the welfare of cancer survivors paramount. In fact, at that meeting, I almost wept, after they mentioned what they've been passing through over the years, the suffering, emotionally, I almost wept at that meeting. And I promised them that if I'll be remembered as the president of the Nigerian Cancer Society, there's one thing, one and only thing, is to address all this plight that you have, narrated. And since we started, I'm privileged to do quite a number of things, including securing national secretariat for NCSA and Abuja and several other, achievements. But that I will not use as parameter for my success. My major goal, how do we address this myriad of challenges being faced by cancer survivors in this country? And to take that proactive step, what I've done is to now organize a national coalition for national cancer survivors. What we have before, we don't have a national coalition. People just work in silos. Some people in Abuja say they have support group, one in Lagos support. We are even confused. And they work at cross purposes. People fight for, fight in the name of potential cancer survivors, but they are fighting in a personal pocket. So what I've done is to break those barriers, establish a national coalition. We now have a national coalition, set up a national executive council where we have officers from all the political zones in this country. It's not from one section, all. They're independent but arm of national society, because we need that national coalition to get national feedback. If she's not here, for example, how will I know that there's a child at national hospital that needs attention? That's the issue. So we need that national coalition that is responsible for looking after that. That has been done, and we have those ESCO. In fact, the Assistant General is somewhere there sitting behind, Miriam, she's there. That is the Assistant General of the National Nigeria Coalition of Cancer Survivors. That is the first step we are taking to have a national coalition, a voice. We need national voice for cancer survivors in this country. We know we are in a very interesting country. You may be passing through a challenge, and if you keep quiet, everybody will jump in and say, you know what you are passing through. But if you shout and you make noise, serious noise, you call their attention to address it. But if not 100%, they will do something. So we need that voice, that national voice, to address that. Secondly, is to take this practice step, to galvanize resources. I like what you have said. I agree to absolutely. We are not depending on foreign investors. That money will be gotten from Nigeria. There is a lot of billions money in this country. If you don't know, I'm telling you. Go and look at money going around local government, the state governors, everywhere. We have billionaires in this country that we even youth. Look at what they do with their money. All those I won't mention their name. The musician. Some of them will just they were celebrating. One bought a Ferrari of how many billion? 7 billion. Another one the following week went to police zone 5 billion. Can you imagine? Make competition using cars. So there's a lot of money going on in this country, and I'm happy that my friend has accepted to share, that committee. So it will work by the grace of God, because I know that, what I'll be judged with is not building secretary, it's the intervention I will make in life of cancer survivor. So by the grace of God, it will work. It's not a political talk, and that's why we are being proactive, taking proactive steps. I make a presentation to the Ministry of Health, and the Honorable Minister of Health, said personally will be there to inaugurate this Friday. And once the committee is inaugurated, they will start action, and that will be addressed. Concerning your daughter, I know Nikrat is handicapped. I'm aware because I'm also part of that committee. There's nothing Nikrat can do for now, because until structure is put in place, they cannot just start spending money. That we are doing with Nikrat. But NCS will take a proactive step. So I will give you my contact. I also visit that your child at National Hospital today. Today, not tomorrow. I'll be there today, to see, and we'll do something to assist the child. Thank you.
Okay, thank you very much, Dr. Monisi. I think you made a number of important points in terms of what we need to do differently. But on the lighter note, you said when you got to know about the huge burden of cancer, you wept. And I remember a minister that was given in charge of our road infrastructure. When you see the situation of our road, she wept, right? But at the end of the day, she left the condition of the road. But that is not going to be your situation. So honestly, we really appreciate the great work that what you do. So Doctor, earlier on you spoke eloquently about how we mobilize funds from government. It's obvious that government has to take the lead, because that is what the political leaders are actually elected to do. But beyond that, we have private sector opportunities in Nigeria as well. Do you want to quickly look at what we need to do quickly, and if you want to answer any of those questions raised by the audience?
Okay, just let me go quickly. Maybe one of the questions that talk about mobilizing resources through the private sector. I think Dr. Gafari mentioned something around business case, or no economic case, but me, I will add the business part of it. Absolutely. So we need to be a little bit technical if you want to engage the private sector. Let me give you a good example. If you are engaging Dangote in Lagos, or Tedola, or Adenuga, all these foundations in Lagos, the question they will ask you is, what is the cost of taking care of one cancer patient? So you need at least an average cost of managing a cancer patient. And for how long? For 5 years, for 10 years, for 20 years. So we need to go a little bit technical. One, at least have a technical team with you to develop a business and economic case of financing cancer patient in Nigeria. Maybe 2-pager or 3-pager with statistics and infographics, and that is punchy and catchy. You can give it to them at the airport. You can meet somebody and share with him. You can share at the Senate. You can even share to people here. So that is number one. Then number two, issue of community engagement. That little awareness on how people can have access to support. If this family are not here today, they might not be able to kind of support. So a lot of community engagement to radio. We have the Berkete family. We have some other radio programs that is happening. Let's create massive awareness on how people can have support. And lastly, the advocacy to the government official. I'm still on my feet that private sector, there's a limit to what they can do. Even the Yahoo boys and whatever, there's a limit to what they can do. Government need to step in and do the needful. Simple. Thank you.
Thank you very much. Great. That's very important. Let me go to lastly our cancer survivors. Guys, I'll come to you to be raising up your hands. So the question to you is this: if we converge here in the next 2 years, what is the difference in the narrative or story we should be telling? What would you like to see that in the next 2 years when we converge, this is the difference that we have made?
Anyway, for me, I would really want to see there should be changes in the sense that, like what I experienced, I was the only one that was virtually dealing with my financial and whatsoever. But just like the earlier on my colleague here said, the CHF comes in, but it doesn't come often. Intermittently, maybe it will come 2 months, after 6 months, just like you earlier said. Before the CHF will come, somebody will die. Let it be better, please. And this cancer, we didn't go and fetch it somewhere and say, this is, we want it. It just came, which people should help. Let it be better. I should not be experiencing it alone, selling my things. No, it's not supposed to be like that. Thank you for the opportunity.
I think nothing captures it better than that. What success looks like is that we converge in this 1 or 2 years. We want to see better access, physical access to start with. Imagine somebody in the corner of Benue that has cancer. To access CHF, he or she has to come to Abuja. That's the fiscal one. Financial aspect of it, we have VHF, Cancer Health Fund, that has covering many people, covering more cancers, and at the same time, covering different dimensions of course. And that is what Madam is talking about in the next 2 or 3 years. That's what will the success will look like. Last, the Madam over there has been raising up her hand. Just quick one, then we'll round off this. Oh, sorry. Please go ahead.
Okay. Sorry, what I want to add on what my other colleague have said is that the CHF are trying, but the problem we are facing is that you may be approved of 500,000, let's say, but your drug is 2 million. So if you take it to the pharmacies cannot even give you anything. If you have 1 million, like I am an example of that. I was given 1 million while my cost of one drug is 2-point-something million. So I have no choice but to go for the lower one, which I have reoccurrence upon reoccurrence, which I am still dealing with it. And the timing, when you have it like for 1 month now, every 3 weeks you are going for that treatment back to the hospital. And like in my own case, I have exhausted, I have sold my house, sold everything, my family, everything for the first treatment. And I have reoccurrence for her too again, which is more expensive than the first treatment. So my family is going through a lot because of this. And the CHF, I know, I thank them for everything, but it has to be, please improve.
Thank you very much.
Yes,
Improvements are very important. And from you as well?
For me, I want to start from the medical practitioners. Please, the way I was being handled abroad from the porter, the cleaners, and the doctors, everybody want me to survive. Everybody want me to survive. They talk to me kindly, they talk to me, they play with me, they take me around. I was a time I was passing, somebody was cleaning the floor. She just said, "Damn, Mom, take it easy. This place is wet. Go do this way." Which we don't have it here. I think that orientation should start from here. We should have that one. Let the cancer patient feel that care that everybody wants me to be treated and well.
Absolutely.
And secondly, since when I was being declared cancer-free, I had my own foundation, Farmers Cancer Foundation, which now my lab, I think I have most of the diagnostic equipments which I'm doing. And I thank God we do reach out to the local governments. Most of the people that believe that cancer is a witchcraft and all this thing, now they don't believe. They come for screening and they accept it. Now we take them, we refer them to other places for further treatment. But still, I need some collaboration so we can do better. Thank you very much.
Thank you very much. The last contribution from the back, very, very important. Especially the point around the responsiveness of the health workers is extremely important. They are doing their best, I think, but the largest room is room for improvement. Over to you quickly.
Good afternoon, everyone. My name is Mariam. I'm a breast cancer survivor as well. It's been 3 years in this journey. I've heard so many things my fellow survivors have said. Truthfully, cancer is a very expensive thing to treat in this country. A lot of people, I myself, I know what I had to go through to have my treatment. When my doctor handed over to me my prescription, I ran out of her office. Over ₦1 million for one chemo. And I was just a civil servant, earning close to 60K a salary. It got to a point, I cried to my doctor. I told her I can't go ahead.
It's okay, madam. It's okay. It's okay.
I had to resort to begging. I had to put myself out there in the social media to beg for me to have acceptine. Thank God I'm done with my acceptine and all that. But aside that, I turned to advocacy because I know that somehow cancer has given me a voice to help other women. I'm here today representing women in the market, women on the streets who cannot come here, who cannot be in this room. That is why I'm here today. I also have an NGO that came after my diagnosis. I've been helping people to speak up because silence is killing a lot of people. Fear. I almost died myself because I was afraid of what the society will say when they see my picture out there. But I had to tell my husband, "Shay, you want me to die?" And I have a 2-year-old son. So I'm encouraging, this is an awareness as well. And the thing is, awareness should not just start in the hospital or just within the seminar. It should be like we should normalize talking about cancer just the way we talk about malaria. We should normalize it because seriously, a lot of people are dying. And for us to have a society free of cancer, we need to start from awareness. Thank you very much.
So thank you very much. So I think you agree with me that we've had a very, very interesting conversation, very productive conversation, which hopefully is not going to be talk shop, which is going to translate to action. Just let me quickly do a recap of a very important point that came out of this conversation. And apologies, madam, you give us only 30 minutes. I guess I will spend absolute apologies, but it's due to the importance of what we're discussing. Number one is very obvious. Cancer is everyone's business. It's obvious. Government, survivors, civil society, organization, every Nigerian is everyone's business. It's very interesting. We've talked about where resources can come from. We have talked about government, philanthropists, and everything. But you know what? In developed world, most of the money that is used, that is brought to Africa for aid, is actually collected from the ordinary people on the streets. Ordinary people, not the like of Dangote and all those stuff. Like when I was in the UK doing my master's, I was doing fundraising. We were knocking door to door, raising money for development work in Africa. We should not leave that part of it because it's everyone's business. Again, part of what came out clearly is that the National Cancer Society is going to be leading a very, very ambitious effort about mobilizing huge resources from different sources whatsoever possible. Again, let's all of us participate one way or the other to support the team that was set up to do this, to provide advice, anything they can provide, technical assistance. My chief here has talked about the need for us to do business case, including fiscal space analysis, to be able to look at we need this money, this is where the money should come out, this is what we need to do. And then we need that to be able to do evidence-based advocacy. It's very, it came out clearly as well. And then again, don't let us miss the opportunity. It came out again that early detection is very crucial. It's a lot cheaper, and we are going to get better result. Again, as we make more effort, we have to talk to the National Primary Care Development Agency. There are a lot of missed opportunity in Nigeria. It's a woman that comes for antenatal that we don't screen for cancers. You will deliver safely, but go a long way to develop cancer and still die. So what is the work done? So service integration is very, very important. As we are talking about mobilizing resources, how do we integrate services? How do we screen people? When men come for different type of consultation, are we doing PSA for them as well to know whether they are going to have prostate cancers and pick it earlier on? I have a brother, we pick it earlier. Now he's living a normal life and all those stuff like that. I think it came out clearly. And then again, having a very strong regulatory framework for this mobilization that we are going to do. The need for us to increase awareness. Awareness is very, very important. Awareness to start about cancers. Like Madam says, some still believe it's a witchcraft and all those stuff that is alien. People thought it is alien. So as part of what we are doing now is going to be very, very important to increase awareness. And then our framework should be able to target all the philanthropists, everybody, including ordinary Nigerian. There are ordinary middle-class Nigerian that are willing to part with 1,000 every month to be able to subscribe to that pool, So these are very, very important. On this note, I would like to thank our panelists for the wonderful contribution. And our biggest thanks to our survivors, who have, mustered the courage to come out, to come and share their story, to motivate others. And they are not only doing that, some of them have set up NGOs because when people operate with sense of purpose and meaning, when things happen to them, it's an inspiration for them to do something to the society. And we really, really appreciate what you have done, madam. So we appreciate a National Cancer Society under the able leadership of my friend, my colleague. He used to bully us with stuff when we were in medical school. He's still doing that up today anyway. But this time around, stuff is translating to action that will benefit the society. Madam, from the health insurance point of view, thanks for the great work from the private sector, and to the NECRAT for the great work that you are doing. Thanks that even the little resources that you have, you don't use it to travel, you use it on the cancer survival. So on this note, I would like to thank you very much for listening. And hopefully, like Madam said, in the next year or couple of years when we converge, the story is going to be different. Thank you. God bless.
Dr. Hanatu? Is Dr. Hanatu here? So she can just join. Prof, please could you join the picture?